Adrenal crisis in the ICU. K. Luft, Minnesota, RN, CCRN. 2012. What do these two have in common? Case study: acute adrenal insufficiency. HPI, PJ, a 38-year-old female is admitted to the ED complaining of progressive fatigue for 2 weeks. She saw her primary physician 4 days ago and was told that everything was fine on her blood workup and that her fatigue was due to depression. She also complains of nausea and vomiting and states she has lost about 16 pounds in the past 2 weeks. She denies any fever, chills, night sweats, cough, or dysuria. She becomes short of breath when walking only 5 to 10 feet. PMH, mild hypertension, premature ovarian failure at age 30. Case study: acute adrenal insufficiency, COMTAD. Social history: single parent, 2 teenaged children who live with her. Lost job as insurance underwriter 1 month ago. Non-smoker, drinks socially once per month. Physical exam. Vital signs: blood pressure 86/40, pulse 118, respiration 18, temp 99 degrees Fahrenheit. Appears pale, dehydrated and malnourished. Rest of exam unremarkable. Case study: acute adrenal insufficiency, COMTAD. Lab: now 129, gait plus 5.7, glucose 62, BUN 19, creatinine 1.0. CT scan of abdomen. Unable to visualize adrenal glands indicating atrophy. Plan of care: sent to the MICU for treatment and monitoring. What is this patient's most likely medical diagnosis? What is this patient's most likely medical diagnosis? What are the clues? What is adrenal crisis? A medical emergency characterized by severe cardiovascular compromise, shock, coma, and possibly death. Is due to severe fluid and electrolyte imbalances related to decreased production of adrenocortical hormones as a result of impaired function of the adrenal glands, primary type. Inadequate stimulation of the adrenal glands by the anterior pituitary, secondary type. Causes of adrenal crisis. Summary of causes of adrenal crisis. Exacerbation of Addison's disease, chronic adrenal insufficiency, often triggered by extreme stress or failure to comply with medication, steroids, regime. Acute physiologic stress, trauma, surgery, severe infection and/or illness. Bilateral adrenal hemorrhage, Waterhouse-Friderichsen syndrome. Adrenalectomy or hypophysectomy. Extreme psychological stress. Quick review of normal adrenal physiology. Pathophysiology of adrenal crisis. Adrenal crisis is associated with inadequate production or release of glucocorticoids, cortisol, and mineralocorticoids, aldosterone. Adrenocortical hormones are necessary for maintaining normal glucose, sodium, and fluid balance in the body. Aldosterone deficiency causes large urinary loss of sodium and water, quickly leading to severe hyponatremia and hypovolemia. As a result of hyponatremia, hyperkalemia and metabolic acidosis often occur. Pathophysiology of adrenal crisis, COMTAD. Hypovolemia is intensified by glucocorticoid deficiency as a result of decreased vascular tone and decreased vascular response to circulating catecholamines, epinephrine and norepinephrine. Cortisol depletion quickly leads to hypoglycemia as body is unable to maintain blood glucose levels in the fasting state. Without treatment, severe hypotension, severe hypoglycemia, coma, and death will ensue. Remember the deficiency in 3 S's: sodium and water. sugar, glucose, steroid, especially cortisol and aldosterone. One sick puppy. Clinical manifestations of adrenal crisis. Profound hypotension, especially postural. Confusion. Muscle weakness. Fatigue, lethargy. Tachycardia. Decreased urinary output. Nausea, vomiting, diarrhea. Abdominal pain. Severe weight loss. Possible hypothermia. Diagnostic findings related to adrenal crisis. Laboratory, hyponatremia, less than 137 MEq/L, hyperkalemia, greater than 5 MEq/L, decreased serum glucose, less than 80 mg/L, decreased serum cortisol, less than 15 micrograms/dL, and aldosterone levels, possible hypercalcemia. ECG, signs of hyperkalemia, peak T waves, widened QRS, lengthened PR interval, flattened or absent P waves, possible asystole, diagnostic findings related to adrenal crisis. Hemodynamic, decreased BP, CVP and PORP, increased heart rate, consult physician for BP less than 90/60, CVP less than 2 mm/Hg, PORP less than 6 mm/Hg, HR greater than 120 bpm. ACT stimulation test. Collaborative treatment of adrenal crisis. Expected outcomes, within 8 hours of initiating treatment. BP within patient's normal range. HR 60 to 100 bpm. CVP 2 to 6 mm/Hg. PORP 6 to 12 mm/Hg. Normal sinus rhythm on ECG. Patient alert and oriented. UO may not return to normal for a few days. Collaborative treatment of adrenal crisis, CONTAD. Identification and treatment of initial cause. Fluid replacement. Rapid volume restoration is goal. D5NS is for fluid of choice. Volume expanders, hetastarch, possible if hypotension persists. Collaborative treatment of adrenal crisis, CONTAD. Glucocorticoid replacement. Immediate 4 bolus of hydrocortisone, Solucort F, followed by maintenance doses every 6 to 8 hours. Mineralocorticoid replacement. Generally unnecessary BO mineralocorticoid effects of hydrocortisone. If emergency treatment needed, fludrocortisone is drug of choice. Collaborative treatment of adrenal crisis, CONTAD. Glucose replacement. Generally sufficient with 4 fluids, but patient may need dextrose 50% initially. Sodium replacement. Generally sufficient with 4 fluids, but patient may need narco 3 initially. Correction of sodium imbalance will shift K+ back into normal balance. Collaborative treatment of adrenal crisis, CONTAD. Vasopressors. May be used if initial treatments are ineffective. Response to vasopressors, catecholamines, and inotropic agents is decreased for patients in adrenal crisis. Collaborative treatment of adrenal crisis, CONTAD. Close monitoring of vital signs, PAP readings, lab results, cardiac rhythm, I&O, and neurostatus. Oral and skin care. Promote rest. Back to our patient. What treatment does PJ need initially? What indicators will reflect improvement in PJ's condition? What follow-up care and teaching may PJ need? Don't forget the teaching. Questions? Cluft@stlukes.org